Welcome to the Computational Medicine podcast, where we discuss AI and machine learning being deployed in medicine. I'm Alex, a doctor and PhD student in AI for healthcare at Imperial College London. Today we are talking to Alex Lebrun, co-founder and CEO of Nabla, an AI tool that listens to medical consultations and transcribes clinic letters for doctors. He previously founded What AI and was acquired by Facebook, and Virtuos that was acquired by Nuance. We discussed how he built the product, where its key uses lie, and his thoughts on how machine learning can benefit medicine more broadly. I hope you enjoy.
So thank you very much, Alex, for agreeing to come on to chat to us today. I'll do a proper introduction of you where I go through your background in a bit more detail. But could you just kick us off by telling us a bit more about your background and how you came to work on the projects that you do currently?
Yeah, so first, thanks for having me today. So I'm an engineer by background, and I started to work on chatbots 21 years ago. So a long time ago, before chatbots were actually cool. And I did the first company doing chatbots for customer service. I ran this startup in France and then in the US for 10 years before it was acquired by Nuance Communications. And then I did another startup in AI space, an AI API for developers that was acquired by Facebook. And so I had the chance to spend 4 years with Facebook AI research, first in the US, and then I moved back to France to help build the AI lab, research lab in Paris, with a lab that has 200 scientists today. And so at this time, we worked on really powerful research, and it's open source, it's public research. And I thought after 4 years, okay, it's really time to try to bring this from papers to actual real world implementation. And we kind of chose the hardest thing we could find, which is healthcare, where everybody knows everything is broken, but it's so hard to make some changes. But we thought for our third startup, and we have good team, good investors willing to take risks with us. It's a good challenge to take on healthcare.
Fantastic. And could you tell us a bit more about the challenges that Nabla aims to address within healthcare?
Yeah, so when we started, we actually interviewed several hundreds of doctors, spent times in hospitals. I attended to actual consultations to look at how they work and what we should do. I know as engineers, we tend to see the wrong problem. We see the problem that is most exciting for us. And we, like many engineers, thought, okay, we will work on diagnostics, improving decisions of doctors. But after a few months, we realized what's really bothering doctors is not doing diagnostics. It's the paperwork. It's the administrative work they have to do. They spend their time filling forms, dealing with NHS, updating your patient record in very old software or on paper. And it takes more than half of the time. It's hard to believe. But if you are a physician, you know that. Actually, some people counted the number of mouse clicks they do during the day, during the shift. It's more than 4,000 on average, mouse clicks in one shift. And so they're really so tired and burned out because of this part of their job. And nobody ever chose to spend 10 years or more to study medicine to eventually become like an admin assistant doing that. And so we decided at Nabla to focus on this side, on the clerical side, not on the medical side for now. And we are trying to just automate away these tasks that take 50% of their time.
I've had a look through, say, the products, but could you just tell us a bit more about, say, how it works?
Yeah, so we started by the biggest pain point, which is clinical documentation, which means, you are a doctor, after every consult, you need to write a note, a clinical note, update some records, filling some claims for the payer or the NHS. And so the way it works for in-person visits, doctors have Nabla on their phone, just on an iPhone, your normal phone. They put it on the table, and in the exam room, they tap on start. And so we will capture the audio. So the communication, the conversation, between the physician and their patient. We don't store it. Very important. I mentioned it right now, but we listen to it. And based on this audio input, we generate at the end of the consultation, after say 15 minutes, we generate all the clinical documentation, and then it's automatically pushed to the electronic health record or any software they have to use to document documentation. We also generate the referral letter. We can generate some instructions for the patient, so very detailed, very without technical words. So we are trying to automate all the downstream administrative tasks following the consultation. And the input is typically the audio of the conversation between the physician and the patient.
How long has the product been around in its current form?
So we've been working more than 3 years on this to collect our data sets. We had to partner with doctors, with patients. It's very sensitive data, of course. Then build our model, and so it took 3 years, and we launched the product 6 months ago in the US, in the UK, and in France mostly.
That product is just so useful for doctors. I'd be amazed if it had been around for longer than a year and I hadn't heard about it. Absolutely fantastic, stellar stuff. Right. You mentioned something quite interesting there in the timeline that you spent going through collecting data, trying to work out how you'd build the product. I guess my question is, what sort of data did you use? Was it all natural language processing? How did you build this product essentially? What models are in there, and how did you go about creating this? Is there an element of ChatGPT?
Yeah, so the data set we needed were 3 kind of data. First, the actual audio recording of consultations. Then the transcript in text of this audio, and then the final note, the documentation. So it means English sentences, but also some codes like CPT codes or ICD-10 codes of these things. So we needed to have for each consultation these 3 things aligned, or at least 2 of them. And so the only way to get that, because you cannot buy data sets, it doesn't exist, it's not available anywhere. So we partner with doctors who are excited by the project, and we also pay them money because they had to spend a little bit of time to get the patient consent, sign consent, explain to the patient why if they agree, what we will do with data, and so on. So it took some time. And we provided a first app where they can record the consultation, and then we paid some medical students to verify the transcript, because so we do a first pass of speech to text, but we pay medical students to correct the mistakes, and then we get the perfect note from the doctor, and also make sure that it's fully anonymous. We don't want any PHI to remain in this data set. So yeah, we took several years to get this data set, and then we had to train 2 kind of models. First, speech to text. So there are lots of speech to text API around. The best, our evaluation says the best is Microsoft Azure. But it's not still good enough for this kind of use case, because if you get very important things like medication names or very complicated illness names wrong, it breaks all the chain downstream. And doctors, you make 1 or 2 mistakes like that, they just give up on your product. And so the out-of-the-box speech-to-text APIs were not good enough, so we had to train our own speech-to-text engine. We eventually ended up fine-tuning a Whisper and customizing a Whisper model. So as you know, it's an open source model provided by OpenAI. So our speech-to-text engine is very, very, very accurate for this use case of turning consultations into text. And it's also cheaper to run compared to if you have to pay Google Speech or Azure Speech to do that. And then the second kind of model we had to train is to get from the text. The text is just the transcript of the consultation, but nobody is interested in that. We are not in the old world anymore where doctors had to dictate into a device and we just write what they say. We want to go from the transcript of the consultation So they are not talking to our AI, they are talking to the patient, but we have to, based on that, guess what would be the perfect documentation. And so this model we started with traditional NLP, so entity extraction, summarization, all these things that we've been working on for 20 years. But some data was hard to extract and normalize from that, especially like long distance, when you say something, but it's spread over like 2 minutes of discussions back and forth. It was very hard before LLMs to get this kind of facts, to extract and normalize this kind of data. And so when LLMs came out in 2020, it was before ChatGPT, but many people haven't seen that. When GPT-3, for instance, came out in the fall of 2020, it finally solved some of the edge cases that we couldn't manage really well. And so today we are using a combination of our own models and GPT-4 to solve this problem. And we mostly use GPT-4 for some edge cases and for kind of training, generating data, quality control, everything, like this kind of thing. But we also need our own model, our models are maybe less powerful, less generic, I would say, but more safe because they are more careful. Like they prefer, when you generate a note, you prefer to leave out something rather than inventing like an hallucination and add something that is not there.
Absolutely,
in the note.
A classic issue with all of the large language models.
Exactly. So you want precision over recall, but actually LLM are not good at precision. And so that's why the right balance between LLMs and other models is what finally worked for us.
I just find that process that you went through fascinating. How you spent a long time collecting data, because this is a massive thing with all healthcare AI. Like the number of papers that are out there where they've got some random data set which is not going to be integrated into seeing patients face to face, and isn't representative of the patients that they end up, the data that they actually end up interacting with. So just going back to say that the data that you collected and then verifying it, because so it sounds like you got because the process sounds exactly like any academic paper that I would have read around AI medicine. It's just that you guys have gone and built a product off the back of it, which almost every single AI paper that you read, all of this top quality stuff, they always end with, oh, and this could be used here. And then barely 5% of these AI medicine papers actually end up being turned into a product. So it's just really fulfilling to hear that, that you've instead of like coming up with a paper, getting a data set, seeing where it can be used and doing this nice, fun pet project, that you started with the product.
We do the
and
exact.
It's the exact same thing. It's just that you've got something that's being used, which is great.
We do the reverse process. We have a problem to solve, and we read, like some people in the team read like 10 papers a day, and we are always looking. Every day there are dozens of new ML papers, and we are looking at new solutions to our big problem. And so we do the reverse process. Like we have the problem, and we read the papers to see which one are relevant to our problem. And we have a good infrastructure in place so that when there is a new model available, we have a very efficient way to quickly know if it's better or worse than the one before. And usually, unfortunately, it's not a binary answer. The answer is it's better for these cases, but it's not worse for this. So should we use this model or not, and how to add it in the mix? So this is, I think, the day job of engineering team working with LLMs and machine learning in general is to make these kind of decisions.
And just on the data that you acquired, so it sounds like you got gold standard. Your ground truths were essentially the documentation from doctors who'd gone about doing it the long way, and then your data labeling was building your model, gathering a large data set on transcriptions and audio, and then applying your model to come up with what the product is now, and then getting it verified. by medical students, and then comparing the difference between the two. Is that roughly the kind of process that you went through for like labeling the data and giving your model feedback on how it was comparing to what the product that you wanted?
Yeah, so to check the final documentation, we used actual licensed physicians, not medical students.
Yeah,
we use medical student for the transcription part. Yeah, exactly.
Yeah. Fantastic, good stuff. And how, what was the size of your data set?
So we have more than 30,000 consultations that are recorded and annotated like that.
On time.
So it's a big. I mean, it's small if you compare to if you are working on images at Instagram. It's very small, but given the how well it's annotated, it's huge.
Amazing. And on the in terms of when it transcribes everything, and the letter that it creates, could you just tell me a bit more about, say, the final product of the letter? Say, because obviously you've got different specialties, GP. Various different hospital specialties. So how does it handle that problem where you've got lots of different types of medical problems that people come in with?
Yeah, so we cover lots of specialties, and there is a feedback loop, learning loop in the product. So at the end of every consultation, the physician can leave some feedback in natural language, like saying, okay, this word is wrong, or this section, like this plan assessment is too long, or you forgot this in the subjective part. So we have a loop to process this feedback, and this loop is improving the product, but there is one track per specialty. So what we do, if I need to cover a new specialty tomorrow, we will fork the general medicine model, and then leave this, call it like orthopedics, and then orthopedicians will actually give feedback on this model and improve it. So this is mostly automated. At the beginning, we do a little bit of hard-coded work we talk with physicians in this specialty to know what they want, and then we leave this model evolve for this specialty. So this is how we are able to cover actually a long tail of specialty. So today, family medicine is the number one, general medicine, mental health is the second one, and then we really have a long tail of specialties, including things like lactation consultants, for instance. So it can be very, very specific.
Amazing. And what have the use cases been like since you've deployed? Say, doctors spend 40% of their time documenting. So, how much time do you think you've been able to save physicians on average in their consultations?
So they tell us testimonials say between 1 and 2 hours per day are saved. So it's a huge impact, and it's also an impact on their stress level, because they are able to close the chart. As I say, at the end, in real time, at the end of the consultation, before the next patient comes in. If there are too many things to do, they just take a few notes during the consult, and then go to the next patient and next, and then back in the evening, back home. This is what you guys call pajama time, at least in the US. They have dinner, they put the kids to bed, and then they have to open their computer, log in on the EHR and close the chart of all the patients they've seen during the day, and they hate that. And this is it's actually working. What we are suppressing is this time where after the fact they document, and it involves a lot of stress, because if they forget something, or if they wait too much time before they close the chart and something happens to the patient in between, it can be a huge liability. So the impact we measure with this product is not just productivity or time saved, but also in terms of wellness of the physicians, and to limit the burnout they are feeling.
Amazing, absolutely fantastic. And so in terms of the quality assurance or the safety, say, what sort of parameter did you put into there? So you mentioned how none of the data is stored locally, fantastic. But I'm guessing that so the the product will email the product emails the physicians the documentation, and then the physicians kind of check the documentation to make sure that they're happy with it. But what other sort of safety measures have you guys put in place?
So it doesn't email. Email would be a breach of wouldn't be compliant at all. And so the product is just displaying the note. So we have either a web app or Chrome extension. It will display the note. When we have the proper integration with the EHR, it will feed the EHR directly through an API. Or if there is no proper integration, when at the beginning, usually they will just copy and paste the note from our tool to the EHR. But it's stored locally on the physician's computer or phone. It's never stored on our server. And so it's HIPAA compliant in the US. We have SOC 2 Type 2 compliance, ISO 27001 in Europe. So yeah, we made it compliant like that. And we don't store, as you said, we don't store anything. That being said, we cannot absolutely guarantee that there is no mistake. When you use ML, if you tell me, I know there is never any mistake, I know you don't understand what you're talking about. And so it's a tool that, we insist the physicians should still check what we generate. Usually it's very short, it's well structured, so it just take a few seconds to check, but they need to check it. They are pressing on the submit button and closing the chart. We aren't doing that in the background without them verifying. So it's important to remember that it's a super autocomplete. When you use autocomplete on writing an email, you cannot say, I didn't read. I just pressed tab. I didn't read the autocomplete from Gmail, and I sent an insult to you. So likewise, you can see that as a super smart, super powered autocomplete, but it still requires the physician's attention.
Yeah, absolutely. That makes complete sense. Fantastic. And in terms of the business model, how are you charging for this? Is it, say, a subscription service, or are people paying outright? Are you working directly with hospitals? So
first we want all physicians to be able to try it, to see if it provides value to them or not, and spread the word. So we have a free edition, up to 30 consultations per month. It's free. And we rely on that we don't have a marketing budget, or we don't do ads, but we rely on that for physicians to just see, if it works for them or not. And so we have this free tier of up to 30 consultations per month. If they want to use it more, they can subscribe for €69 per month in Europe, and $119 per month in the US. So it's a monthly subscription, and this is what independent doctors or small practices use. And then when our go-to-market actually is when in a big health system or a big hospital, more and more doctors are using it, then eventually they will talk to management, to purchase department, and we'll have a global contract. And at this point also, if we need to do specific integration so that the note is fed directly into their system through an API, it's possible to do it with this kind of contract. So we start bottom up. It's very important for us to be like a grassroots go-to-market motion, product-led growth, actually, PLG. We are trying to talk to physicians directly, and the two advantages for us is first, they become our champions when we do enterprise contracts, and second, we keep this very close relationship with our community of users, and we couldn't have put grown the product to this stage of accuracy without this partnership with our community. And so by going directly to physicians, we also have this community that helps us to improve the product every day.
Amazing. And what sort of features or what sort of feedback have you had since launching that you weren't expecting to get? Like, what sort of ideas or particular things were doctors asking for that you weren't expecting?
So many, actually. So it's interesting to see how doctors are first resistant to, averse to change, but then once they trust something, they have many ideas and ask for more and more. So we love this moment where trust is established. One of the thing, the first thing they required is patient-facing functions, like what we added recently is after visit summary, or patient instructions, it's sometimes called. So we generate a special note to give to the patient, and so this note is very detailed. It has no specific, medical two medical terms, and patients are really, really happy to have something nice and that they understand after the visit. Lots of studies shows that patients only remember and understand 15%, of what the doctor said during the consultation. And so they forget 85%. And the goal of these patient instructions is it makes everybody's life better. Patients are happy to have everything with them when they leave. And on the physician side, the probability that this patient will email them or call the office because they have a side effect they didn't expect, or they didn't understand how to follow the treatment, it's really decreased. So it's a win-win feature. So it's just one example of something we added following physicians' feedback.
Fantastic. This is all completely reminding me of Dr. Eric Topol's books, Deep Medicine and The Patient Will See You Now. In there, he goes over and over again how this coming wave of AI and computation is going to give doctors the time back to properly give patients the face time. Like like GPs in the UK, for example, they have 10 minutes per patient, and that's to find out the problem, to diagnose it, to examine the patient, to tell them what the problem is, and to document, all in 10 minutes. It's absolutely I have no idea how they do it in 10 minutes, but and the entire process will be spent, and you're seeing it more and more, but the entire time is spent at the computer, staring at the computer. So just I can imagine that one of the main things would just be that the doctor is able to put record on their phone and actually speak to the patient, make eye contact with the patient. I think that's got to be one of the biggest things, that you're not, particularly general practice. I think that it's not that. I think in the UK they do tend to be one of the more time pressured ones in terms of patients that they see in a day. But that must be a fantastic change for the patient and the doctor to just get that quality time where you're not having to worry about documenting.
Yeah, exactly. We just remove, and we actually see that, some doctors send us pictures of their exam room where they remove the screen or altogether, or put the screen against the wall, not on the desk between the patient and them. And you can see them talking to the patient face to face for the first time since 60 years, before the computer entered the room. And so far, computers enter the exam room. It has been a very bad news for physicians since the last 50 years. It only brought more things to do they don't like, liability, task, and what we hope to do with AI is to finally remove this bad news that arrived 50 years ago with computers. and another thing that patients love and we didn't expect at all is that because doctors so quickly they adapt to their AI, and they know that, for instance, if they do a physical exam on your knee, but they don't say anything, there is no way for the AI to document that, because we don't know what happened in this. We don't have a camera. And so, but they get it, and so quickly doctors start to verbalize what they do. Okay, I'm doing exam Y, result X. This is normal, this muscle. So they will verbalize more and more because they know they won't have to add this to the notes.
Fantastic.
Because of Copilot. And actually, the side effect of that is that patients feel, wow, it's very technical. It must be very good care. And the more the doctor verbalize, and I think we all experience this as patients, the more your doctor is verbalizing, the better you feel. And so it's a side effect that we observed recently.
Absolutely, and I guess that's there's feedback on both sides. There's feeding back on the product, but also feeding back on how best to use the product. So any other any other sort of ways that physicians kind of slowly got used to using it? So yeah, verbalizing their examinations. That's a classic. That's a really poignant one. But are there any other ways that the clinicians have kind of had trained to that are really common pitfalls in how to use the product?
This is the main one. So now sometimes they prepare before the consultation starts. They will like feed the first context to the copilot about the patient if it's a like follow-up visit. So we also observe that, and the product was not meant to do that, but it works well. And finally, we did something for the US physicians that they were asked for, and it's great, is the ability for the copilot to understand Spanish. And so in this case, it's for the US market, so the consultation will be in Spanish, but the documentation should be in English. And so our copilot is able to manage this kind of situation, and it's very powerful.
Yeah, fantastic. Amazing. Okay, so next question is, so where do you see, obviously this product's been launched 6 months ago, so it's early days. Obviously you want to make sure that you deliver this product well, but in the future, where do you see Nabla going generally within healthcare?
So yeah, we launched 6 months ago, but we are currently at the run rate of 2 million consultations per year, so it's already used a lot. Mostly in the US today. And we are starting to sign with very big healthcare health systems in the US, so for thousands of physicians at once. And so the go-to-market is already bootstrapped, I'd say. And in terms of product, we'll just follow what physicians ask for. Like I mentioned, the patient-facing features. They want their copilot to be more and more personalized, to learn what they prefer. You will never find two doctors who agree on what is the best note. And so there is no solution other than make it personalized for us, and that your AI is learning what you prefer and adapts to that. So this is a big track in the roadmap. And more generally, every time physicians will tell us, okay, I'm doing this task that is really valueless. Can you do it? We'll try to train the copilot to do it. So our roadmap is easy to do actually because we follow their requirements.
Fantastic. So what advice would you give to any healthcare professional or organization looking to implement their Nabla into their practice?
I think they should be curious. Instead of thinking too hard about what to do, which tool to use, or I'm really pushing them to try. It's very easy to ask a few physicians, who want to volunteer to be in a small pilot with 20 physicians, and then in our case, they can go to nabla.com and start using it without even having to create an account. So I'm not talking about a 6 months project involving many things. So it's very easy to try. We made it very easy to try, very safe because we don't store data. And I think and maybe Nabla is not the best product for them, but others. But I think I'm really a big believer of trying things, exploring, being curious, within, of course, the limit of compliance. But and in general, this is true for AI. I think many people are trying to think too hard about AI, what it is. Is it, is it a good thing for my job or a bad thing? And I think the people should just use whatever, ChatGPT or anything. There are so many tools, AI-powered tools. And I think they should see by themselves and try in practice. And I think healthcare organizations like others should work on practical things.
And backtracking a little bit to the data sets that you were using in building the model. So where did you go about sort of gathering the data for building the model? So obviously it's difficult to acquire to large scale data sets, etc. So yeah, what were your sources?
So we worked. So first, when we started the company, we actually created our own virtual primary care clinic in France and in the UK.
Right.
So we started. We didn't get a huge amount of data from that, but we started to see how physicians work, how to best cooperate with them, and so we learned many things, and also we got some data sets. And then we partnered with physicians in France, in the UK, and in the US directly to collect this data set. And they don't do most of them didn't do that for money. They did that because they liked our vision as a company, and they thought we were trustworthy, and that they were excited to work with us to try to make a change and make a dent in the healthcare problem. So it takes a lot of time also to find these people, in the big picture.
Yeah, absolutely. And do you have any advice for students generally?
For medical students or
any students?
My advice for students is the same as the one for organization. Be curious, try things. It's so easy now, even if you don't know code, to play with no code tools, to develop with AI. I think AI is really a new superpower for all jobs, and people who will master this will have a better life. They'll be more efficient. They will have less stress in their lives. They'll be more productive, and that there is no official. It's not a school or a university you should attend to do that. It's just be curious and start to use these things. Make your own opinion instead of reading news, because the press is really 90% bullshit when they talk about AI. They don't understand anything. And so make your own opinion, be curious, play with the different tools. And I think this is the best thing to do now.
Amazing. And do you have any good book recommendations?
A book recommendation, a good question. So the book I recommend is not a business book. It's not a technical book. And it's actually a French book, so maybe it won't, but it's translated. It's a book by Marguerite Yourcenar, a French author, called Mémoires d'Adrien. So probably memories of
Memory
Hadrien.
Durian. Yeah, memory. Was it Durian?
Hadrien.
Hadrien.
Hadrien. So it's not a business book. She wrote this book in the 50s. But it's the best business and also personal life, I think, book I've ever read, and you should judge by yourself. But it's an incredible book.
Yeah, fantastic. I'll have to pick up the English translation or muddle through with my GCSE level French. Okay, so moving on to the last question. So I'm now asking all guests this, and I think it's important that we all sort of think about this more generally. But what are your thoughts on AI safety outside of medicine generally?
So first, as I said already, I think 90% of what is written about AI safety is completely ridiculous. But of course, if you want to have many clicks on your post or your article, you need to say that AI will kill humanity. And so other people, like Yann LeCun are much more in a better position than me to speak about that. But I'm not saying it's not a problem. And I'm not saying we should ignore AI safety, but what I'm saying is 90% of what we say is completely crazy and derived from our, the movies we started to see in the 60s with Space Odyssey, where Al is trying to kill the astronaut and so on, and we still have this fantasy around us. So that being said, so for instance, I think fake news, the capacity to do deep fakes, or to generate a lot of content to troll and to impact a political election. This is, for me, the real danger of AI today. It's not a robot trying to kill humanity. So we have to work on this. I don't think that preventing people to building models like OpenAI is trying to push, with the Congress is a good idea. On the contrary, I think making things open source, and making also using AI to make the world safer and fight against these kind of deep fakes and others is the best solution. So I think we should mostly train people better all people to use AI to be more cautious, to determine when something is actually fake. For instance, if I draw on this example, instead of closing all doors or saying AI is forbidden because it won't happen. So this is my personal view on AI safety. We should do something, definitely, but not definitely not for making things forbidden or closing doors.
Fantastic. Yeah, I remember reading recently that Andrew Nung, said, "Oh, worrying about AI or artificial general intelligence right now is like worrying about overcrowding on Mars." That you definitely see two sides of it, as in a big split, particularly on Twitter around concerns and everything. Okay, thank you very much, Alex. That's fantastic. The really great chatting. The work that Nabla is doing looks absolutely sensational. Really fantastic to have you on to chat today. Thank you so much for joining us.
Thanks, Alex. Thanks.
A big thanks to Alex for taking the time to talk to us. You can find links to all of his work in the description. Thanks again, and catch you next time.